In this episode of the Nurse Practitioner Podcast, Dr. Julia Rogers and Dr. Marianne Schallmo discuss abdominal pain and urinary tract infection. What is the significance of understanding the pathophysiology of abdominal pain?
It is important to understand the pathophysiology associated with abdominal pain because it is one of the most common gastrointestinal complaints evaluated in the primary care setting. We also know that abdominal pain evaluation can be challenging, as a diagnosis is often elusive. There are several reasons for this elusiveness. The abdominal pain evaluation is complex because patients may present with vague or referred symptoms. Also, a variety of disorders can cause abdominal pain. Disorders originating in the cardiopulmonary, genitourinary, reproductive, musculoskeletal, or gastrointestinal systems can all elicit abdominal pain. When we discuss the pathogenesis of abdominal pain, the exact mediators and occurrence of how pain is experienced is not completely understood, but it is known that abdominal pain type, quality, intensity, and location depend on activation of abdominal nociceptive receptors. These pain receptors are perceived via three afferent relays: somatic, visceral, and referred. Somatic pain arises from cutaneous or deep tissues and occurs in bones, joints, connective tissue, and muscle. Referred pain is visceral pain felt along the same skin dermatome or shared afferent neural pathway, but at a site distant to the original visceral pain site. Finally, patient perspective or past experiences can also influence their pain. One of the most common causes of abdominal pain is urinary tract infection.
UTIs are initiated by an inflammation within the urinary epithelium caused by the same bacteria that inhabit the gut. Acute cystitis is caused by an inflammation of the bladder and is considered a lower UTI. The most common cause of bladder inflammation is infection, and the most common route of infection is ascension of bacteria from the urethra to the bladder. In a lower UTI, bacteria do not ascend beyond the bladder. In acute polynephritis, an upper UTI, bacteria replicate within the bladder, ascend, and invade the kidney through the ureter or spread to the body through the bloodstream. In healthy individuals, the body's natural host defense mechanisms maintain a sterile posterior urethra and bladder. The presence of a UTI occurs when bacteria are able to circumvent or overwhelm the body's natural host defense mechanisms. There are several natural protectant factors within the genitourinary system to avert UTIs. The body's maintenance of a low pH and high osmolality of urea produces a bactericidal effect along with the presence of uromodulin and secretions from the urothelium. Both males and females are protected by the periurethral mucus secreting glands. These glands provide a layer of protection by trapping bacteria before it can ascend from the proximal urethra to the bladder. The body's immune system is able to detect and destroy bacteria that are able to ascend to the urethra if they come in contact with the bladder wall. The closure of the ureter-vesical junction during bladder contraction prevents urine reflux, thereby preventing bacteria ascension from the distal urethra to the ureters and kidneys, deterring an upper urinary tract infection. Finally, micturition is the final process by which bacteria are flushed out of the urethra.
Explain a little more about the complexities involved in the evaluation of abdominal pain.
The key to effective abdominal pain management is using the patient's history, physical examination, and diagnostic findings to quickly identify the underlying cause and determine if the etiology is acute or chronic. If the cause is acute, the nurse practitioner must differentiate between emergent and non-emergent causes. Here are some clues to determine the etiology of pain. Evaluating the pain type, quality, and location will help the nurse practitioner determine the etiology. So let's delve deeper into understanding pain types. The quality of somatic pain tends to be asymmetric, well localized, and described as sharp. Because somatic innervation is unilateral, patients with somatic pain are able to pinpoint their precise pain location. Somatic pain is intensified by sudden movement, deep inspiration, or applying pressure on the abdominal wall. An example of somatic pain is postoperative cholecystectomy pain. The quality of visceral pain tends to be described as vague, cramping, dull, and aching. Visceral pain has a diffuse location. Remember, visceral pain occurs in hollow and solid organs. Organs are encapsulated and enriched with many nerve endings. These nerve endings also innervate several other abdominal visceral structures. And then those nerve endings bilaterally enter the spine neural pathway at different levels, thus causing diffuse pain. For example, pain caused from appendicitis is visceral pain. Patients with a distended appendix may locate their pain by moving their hand across the periumbilical area. Their pain location is vague and diffuse because the small intestine nerves bilaterally enter the spinal cord pathway at level T8 to L1. Finally, there is referred pain. Patients with referred pain can have a combination of somatic and visceral pain, but it is well localized. An example of referred pain is acute cholecystitis presenting with pain in the right scapula. As you can see, abdominal pain has many facets, which adds to the complexities of an abdominal pain evaluation. Julia will discuss pain manifestations of UTI presenting with visceral abdominal pain.
Since abdominal pain can lead to a multitude of diagnoses, can you talk a little bit about a common cause seen in primary care?
A diagnosis of urinary tract infection is classified as upper or lower and can be uncomplicated or complicated. Uncomplicated UTIs present with mild symptoms of urinary frequency and dysuria and occur without any functional or anatomical anomalies in the urinary tract. A complicated UTI develops from an anatomical abnormality or when the body's host defenses are compromised from an underlying health issue such as diabetes, renal transplant, spinal cord injury, or human immunodeficiency virus.
Explain how the patient's report of certain clinical manifestations involved with abdominal pain can lead to a specific diagnosis, such as a urinary tract infection, based on the pathophysiologic processes of disease.
Understanding the patient's perception of pain will help the nurse practitioner determine the differential diagnoses. Therefore, a thorough history and physical exam is critical in both developing and narrowing the differential diagnosis involved in abdominal pain. Using the mnemonic PQRST can assist the nurse practitioner in obtaining pertinent information for the history of present illness and will guide the development of appropriate differential diagnoses. Of the P meaning precipitating causes, Q, quality of pain, R, region and radiation of pain, S is subjective description of pain, and T, time pain occurs. It is equally important for the nurse practitioner to obtain information regarding social history, travel history, family history, recent sick contacts, recent hospitalizations, medications, and other medical conditions. Medical conditions are important as some may alter pain perception. For example, patients with diabetes may not experience pain due to neuropathies. The abdominal exam can elicit important details to make an accurate diagnosis. For example, does the patient have rebound tenderness? Is there a positive Murphy sign or Carnett sign? One key assessment finding is discovering a pulsile abdominal mass, suggesting an aortic aneurysm. Additional examinations should be based upon initial findings. For example, a rectal exam should be performed if fecal impaction is suspected. Males should be checked for hernia, testicular swelling, mass, or tenderness, and females may need a pelvic exam to assess pelvic pathology. Patients presenting with abdominal pain may also have a genitourinary disorder, such as a UTI, which has specific associated manifestations.
The positive predictive value of acute cystitis screening is 90% in patients that present with new onset of polyuria, dysuria, and urinary urgency. Hence the importance of documenting a thorough history of present illness, which would include symptom onset, exact location of dysuria, duration, timing, context, associated symptoms, and modifying factors. The clinical manifestations of UTI are directly related to the inflammatory process within the genitourinary system. The inflammation in the bladder wall stimulates stretch receptors, initiating symptoms of bladder fullness with small amounts of urine and producing the urgency and frequency of urination associated with cystitis. There are sensory nerves located just beneath the urothelium that can invoke pain when stimulated from the inflammatory process associated with UTIs. thereby provoking the symptoms of dysuria and suprapubic, flank, or low back pain. Pain occurring at the start of urination may indicate urethral pathology. Pain occurring at the end of urination is usually of bladder origin. Other associative symptoms include hematuria, urinary incontinence, nocturia, and malodorous urine. The elderly are at increased risk and have a higher rate of morbidity and mortality, but they may only present with confusion or vague abdominal discomfort. The physical examination is typically normal for uncomplicated UTIs, although suprapubic tenderness is present in about 10 to 20% of women. The nurse practitioner should suspect acute polynephritis if a patient is ill-appearing, seems uncomfortable, and presents with a fever, chills, tachycardia, nausea, vomiting, flank pain, incontinence, and dysuria.
Discuss the treatment for abdominal pain and specifically urinary tract infection as it relates to the pathophysiologic process of the disease.
When nurse practitioners treat abdominal pain, the suspected diagnosis drives the treatment plan. Treatment for abdominal pain can be divided into emergent or non-emergent care. A thorough history and physical will identify red flag indicators. Patients presenting with these red flags will require emergent care. Red flag symptoms include fever, unexplained weight loss, pain that awakens one from sleep, immediate severe pain, or chronic pain with new acute symptoms. Other red flags include jaundice, chest pain, tachycardia, tachypnea, or hypotension. Any hematemesis, hematochezia, severe vomiting, or diarrhea are also emergent symptoms. Patient presenting with red flag symptoms need immediate referral to the emergency room, gastroenterologist, or other subspecialists for further evaluation. All non-emergent cases are generally treated in the outpatient setting. Since the list of differentials is quite long, Julia will discuss the treatments for urinary tract infections.
Cystitis in symptomatic individuals is diagnosed by urine culture of specific microorganisms with counts of 10,000 colony-forming units per milliliter or more from a properly collected clean midstream urine. The most common pathogen associated with uncomplicated UTI is E. coli, representing 86% of all cases. Acute polynephritis is diagnosed based on clinical manifestations and characterized by a urine test showing pyuria. The most recent guidelines for treatment of uncomplicated cystitis and polynephritis in women were released in 2011 and provide 3 options for first-line treatment of acute uncomplicated cystitis. Those are nitrofurantoin and the combination of trimethoprim, sulfamethoxazole, or fosfomycin. Fosfomycin has minimal resistance, but has inferior efficacy and is not widely available in the U.S. The fluoroquinolones, while highly effective, should be considered alternative antimicrobials and be reserved for infections other than acute cystitis due to the tendency for ecological adverse effects such as antimicrobial resistance. Beta-lactam antibiotics are also not recommended for initial treatment because of concerns about resistance. If a urine culture and sensitivity are ordered, the urine specimen must be obtained before the initiation of any antibiotic therapy. Initial empirical therapy for polynephritis should be tailored appropriately based on the infecting pathogen and severity of illness at the time of presentation.
Can you speak a little bit about billing for abdominal pain and urinary tract infections, since both are in the top 12 billable common diagnoses in primary care?
The ICD-10 is the standard billing code system used when submitting diagnosis codes for insurance reimbursement. It is imperative documentation support the billing code. All abdominal and pelvic pain use the R10 base coding system. The R10 codes should not be used alone, but instead be used in conjunction with a subcode. The subcode purpose is to further delineate abdominal pain by severity and location. Severity is categorized by intensity level. These categories include acute abdomen, abdominal pain, abdominal tenderness, rebound tenderness, colic, and generalized pain. Abdominal pain, tenderness, and rebound tenderness are further subdivided according to pain location. Location includes upper abdomen, pelvic and perineal, and lower abdomen. The location code is also divided into either right or left abdominal side. As with all billing, the most detailed ICD-10 code should be submitted. The R10 code group is only used for signs and symptoms when a definitive diagnosis is unknown. If a diagnosis is determined, the known diagnosis supersedes the R10 code. For example, when a patient presents with a complaint of abdominal pain and upon evaluation is determined to have gastroesophageal reflux, the ICD-10 code for gastroesophageal reflux should be submitted.
ICD-10 codes related to diseases of the genitourinary system start with the letter N and are listed under N30 through N39. The code associated with acute polynephritis is N10. Codes B95 through B97 should be used in conjunction with code N10 to identify the causative pathogen. B95 is the code for Streptococcus, Staphylococcus, and Enterococcus. B96 is the code to identify other bacterial agents, and B97 is the code to use for viral agents. Each of the B codes are categorized even further to identify the specific infectious agent if known at the time of billing. For example, if a patient has known Streptococcus A polynephritis, then the code B95.1 would be used along with the billing code N10. It is imperative for the nurse practitioner to document supportive information within the patient's chart to provide justification for the billing codes. The ICD-10 code with the highest specificity will increase reimbursement. Therefore, if the offending pathogen is known, it should be billed appropriately.
What are the implications for nurse practitioners in managing patients that present with abdominal pain possibly caused by UTI?
Nurse practitioners are well suited in managing abdominal pain conditions. These patients often present with a wide array of symptoms, creating the possibility of many differential diagnoses. Determining the exact cause often requires time, meaning multiple office visits and diagnostic testing. Not having an immediate answer can lead to patient frustration, decreased quality of life, and increased cost to the patient and the entire healthcare system. Nurse practitioners, with their holistic approach, advanced knowledge, and ability to collaborate with other healthcare team members, are in a perfect position to not only provide high-quality care, but also offer much-needed patient reassurance.
Nurse practitioners play a vital role in decreasing the virulence of pathogens by mitigating prescription usage in patients with UTIs. The foremost responsibility is to protect patients from preventable harm. The appropriate use of antibiotics can safeguard patients by curbing resistance. The CDC's core elements of outpatient antibiotic stewardship outline strategies for NPs to follow, including the use of evidence-based diagnostic and treatment recommendations. Important considerations for the nurse practitioner when caring for a patient with a urinary tract infection is prescribing the correct antibiotic by the right route for the shortest duration. Nurse practitioners represent the fastest growing segment of the primary care workforce and are more likely to serve minority and underserved patients. Therefore, it is important that nurse practitioners provide judicious, cost-effective care to their patients. UTIs are the leading cause of emergency hospital admissions for acute conditions that could be effectively managed in the community in an outpatient family practice care setting. This podcast hopefully provides the clarity needed to help nurse practitioners differentiate abdominal pain to make an accurate diagnosis. By having the correct diagnosis, NPs can reduce inappropriate antimicrobial prescriptions and improve antimicrobial stewardship.
This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer.